evening, everyone. Welcome to the IPNA Endorsed Webmaster Series 2020. It runs till December 23rd. Today, we have three eminent speakers. The first speaker is Dr. Manoj Matnani. So Dr. Manoj Matnani is a consultant pediatric nephrologist at Jahangir Hospital and KEM Hospital, Pune. He is as well a professor at Dr. D.Y. Patel Medical College, Pune. His specific interest is towards nephrotic syndrome, tubulopathies, pediatric renal transplantation. He has got the national award for as Dynamic Indian of the Millennium and has been awarded the gold medal, that is Dr. B. Balagopal Raju Endowment Award for his research work on nutritional value of topical oil application in neonates in 2003. Over to Dr. Manoj. Dr. Manoj. Dr. Manoj, you're there online?
Give us this opportunity to share with you all our views. Hear me?
Yeah.
Do you hear me? Yeah, I am online.
Yeah, we are able to
online.
hear
Can you hear me?
Yeah.
Yeah, okay. Thank you. I'll just go ahead. Yeah, okay. Thank you. So I'll just once again thank Kalaivani and Dr. Dr. Namalwar for inviting us. Let's start with the presentation. My topic today is something about immunization in nephrotic syndrome and also CKD. So, otherwise immunization feels to be a very dry topic, and it's more of a topic people feel is for interest for general pediatricians. But let me just put a few case scenarios and try to highlight why is it important for pediatric nephrologists as well. These are not factitious cases. These are cases from personal practice. So an 18-month-old who's due for his vaccines but develops first episode of nephrotic syndrome, what to do? I'll just quickly go through the cases. 7-year-old steroid-dependent nephrotic syndrome, 7-year-old, a known case of steroid-dependent nephrotic, who's not received pneumococcal vaccine as yet and presents with a full-blown relapse and spontaneous bacterial peritonitis. Another case, 9-year-old boy with dense deposit disease. We have general pediatrics people also in the audience, and also trainees. So DDD's dense deposits basically a type MPGN type of pattern and a progressive kidney disease on long-term steroids and MMF. Similarly, an 8-year-old girl with lupus nephritis class 4, IV methylpred, cyclophosphamide monthly pulses and MMF thereafter. An 18-year-old rural boy, completely unimmunized, a very common scene in India. We see this diagnosed as CKD due to dysplastic kidneys, stage 3 and on conservative management. So what do we do? Another 8-year-old girl with ESRD, CAPD for 3 months, and a living-related transplant plan from the father in the next coming 6 months. What do we do? What is the checklist for immunization? And lastly, a 9-year-old boy with malignant FSGS who proceeded to ESRD within just 2.5 years, doing good on CAPD, but living-related plan from the father in the next 2 months. So it's just that the time is quite limited, just 2 months, and you're supposed to transplant the child. So what is common with all these cases is basically they're all on immunosuppression and steroids. So we just need to be careful what we need to do. And these patients have a lot of morbidities, comorbidities as well. So the general pediatricians usually are difficult to, they find it difficult to give the immunization, and therefore they would really bank on us. And we as pediatric nephrologists sometimes bank it fully on the pediatrician colleagues. So I think it's important that as pediatric nephrologists, we need to really guide them on when to give and what to give. So this talk is all about that today. So quickly, the highlights of the talk are immunization in nephrotic syndrome, immunization in immunosuppressed due to either steroids or other agents, immunization in children with CKD or ESRD, what is the recommended schedule, and for immunization in a child awaiting a renal transplant. And lastly, we'll be covering a few slides on immunization of household contacts. It's important to know that, and vaccination, if any, whether can be given post-renal transplant. If you look at this figure, it tells you that active immunization is very important. It can only be given by live vaccines, and it stimulates the proliferation of T and B cell, resulting in the memory response. Sometimes this is also called the anamnestic response. In quite a few books, it's written anamnestic. So basically, it means the T cell dependent, which produces a lot of memory cells. And this memory cells, the anamnestic response is very important. This is forms the basis for the permanent effect of vaccination. After once you give a vaccine, then you are really, the body sort of can relax, and the B cells and the memory cells can take over and help us. If you look at this slide, this graph, the first one is just some toxoid or inactivated vaccines which will increase and give the antibody titer maybe max up to 1:32. But more important is, you can see 1:2000. This is the immunologic memory which is given by live vaccines. So all of us need to realize the importance of live vaccines, more so particularly in nephrotics and CKD patients. Well, now it's the COVID times, unprecedented COVID times are there, and all of us are hearing about this herd immunity now more than before. And you know, herd immunity, I'm not reading every slide in detail, but herd immunity is important. It helps in eradication of various diseases. And more important is to understand that when enough people are vaccinated, the chance of that pathogen infecting the non-immunized population then becomes very small. So it's important, herd immunity in CKD patients, because when they are staying at homes with other siblings around, what they can get benefit is, if the child is in the household vaccinated with some live vaccine or the other, it helps in giving herd immunity to that child, to the CKD child, which is also protective. Vaccine efficacy normally would be calculated by this simple formula: attack rate in unvaccinated minus the vaccinated upon the unvaccinated. But this cannot be applied to our renal patients, because there are less number of patients who are, I mean, first of all, though there are big registries all over the world, North American registry of the renal trials and collaborative studies, that's in Napractis, they have a good data about CKD, but the numbers are still small. And in India, though we have the ISP and CKD registry going on, but we can't evaluate the efficacy because numbers are too small. So what we can really evaluate is a surrogate marker, which is nothing but the immunogenicity and the seroconversion. So that's what will help us, and quite a few studies basically have evaluated that. I basically would give credit to two studies. I haven't, for some reason, I was not able to load those slides. I'm sorry for that, but I'll just tell you Pediatric Nephrology 2002 and 4. It's quite 18 years ago, but there are these two landmark papers from people from Switzerland. It's Thomas Lobe, Guido Lobe, sorry, and Thomas Newhas. If you can just Google them, 2002 and 4. They are these pediatric nephrologists from Switzerland who have really done a lot of work in vaccination, in immunocompromised state, and in CKD. So now let's move on to the main talk about nephrotic syndrome. Again, for the trainees and for general pediatrician colleagues, we know why a nephrotic child, you know, even if you forget corticosteroids, a nephrotic child per se by the disease process is highly immunosuppressed. Because of these reasons. There's decreased humoral immunity, there's decreased T cell immunity because of abnormal T lymphocyte transformation. Then your complement system is disrupted because you lose factors like I and B, and even factors B and D. Even properdin is lost, which is needed for the complement activation. There is decreased splenic function. Obviously, there's edema, which is a good source of culture medium for bacteria and other organisms. So we know that the child is a nephrotic child, otherwise is fully at risk for infections and is immunosuppressed. If we look at one particular infection, which is Streptococcus pneumoniae, I would spend some time on that. We know I'll be covering the mechanism of the vaccination in detail in the next few slides, but we know that there are two types of vaccines. One is polysaccharide vaccines and the other is conjugate. So polysaccharide, the serotypes have evolved. Now we have 23 serotypes, and conjugate, we started with heptavalent, and majority of the studies in literature have been quoted with heptavalent, that is the 7 serotypes. Whereas the latest one, which is the 13-valent, there are not many studies, but people are using. And let me just tell you, a nephrotic child who's treated, obviously we know it's treated with steroids and many other immunosuppressive agents. a quick look at why are steroids and why are those other immunosuppressants immunosuppressing in nature. We just need to understand the mechanism of action. I don't want to bore you with too much of details, but if we can just understand that the glucocorticoid comes on the cell wall here in the cytoplasm, after attaching to the glucocorticoid receptor, it goes down and then finally fuses with the GRE, which is the glucocorticoid response element. So what steroids do is, at this stage here, they induce the heat shock protein, which is an inhibitory protein, which in turn then, through this GRE element, the response element, it causes transcription of anti-inflammatory components. And it has also another component called HDAC2, which is the deacetylase mechanism, by which it inhibits this. This is also a very good thing. I mean, as pediatric nephrologists, you know it very well. The nuclear factor kappa beta and the activating protein 1. This complex, which is needed to form the pro-inflammatory cytokines. We all know cytokine storm. We have heard of it more now than before because of COVID. This is the way it becomes anti-inflammatory. So steroids are generally called broad spectrum anti-inflammatory and broad spectrum immunosuppressants because that's what they do. They work at a nuclear level and they just block the transcription of everything which is inflammatory. I would not spend much of time. It just is trying to highlight the importance that immunosuppressants work on these mechanisms. It's basically T cell receptor stimulation followed by the entire cytoplasmic and the nuclear actions. And then they release all those various cytokines. And then there is T cell proliferation through these various signals. We know calcineurin inhibitors. We know they work on the NFAT, that is nuclear factor of activated T lymphocytes. As I told you, the AP activated protein 1 and the steroids working through nuclear factor kappa beta. So just again for the trainees, tacrolimus through the FK binding protein, these are called CNIs, cyclosporin, and these work here. They dephosphorylate from NFAT-P to NFAT. Corticosteroids I've already covered. Basiliximab, IL-2 receptor blockers, many sort of anti-lymphocyte agents. Azathioprine, it works on the phosphoribosyl transferase, thereby causing purine inhibition, along with MMF, which works on the inosine monophosphate dehydrogenase. So in effect, all these immunosuppressants, now we know, we have got a gist where they work on. So now we move on to immunization in nephrotics. Having had a background, what we need to remember, this was published also in our Indian pediatric guidelines way back 12 years ago. Any patient receiving steroids at 2 mg per kg per day or greater, or a total 20 mg per day for more than 2 weeks is immunocompromised. We need to understand that. It applies to all these agents. Such patients obviously can't be given live attenuated vaccines, but inactivated or killed vaccines are safe. And obviously we can restart the live vaccines once the child is off all these meds, at least for 4 weeks, 1 month. And very rare unfounded fears are there that administration of some vaccines, particularly MMR, hepatitis B, or meningococcal vaccines may rarely precipitate a relapse. I'll just come to that in later. This is the slide which I was talking about. We need to understand in pneumococcal vaccines. It's simple. If you have a polysaccharide molecule, which is the polysaccharide vaccine, what it does is it just induces the T cell independent B cell activation, by which I mean it stimulates the B cell and forms plasma cells and then IgM. So it doesn't have a memory response. Because of this, you really can't rely. You have to keep giving boosters every 5 years, and also it is not effective in children less than 2 years. Therefore, to make it more effective, what is done is the polysaccharide molecule is linked to a protein carrier, and this process is called conjugation. So we are aware of the conjugate vaccines. We started with heptavalent 7, and now we have 13 serotypes. And when you do this conjugation, then the T cell process comes into play. The T cell then further activates the B cell, and this produces what is called the memory response or the anamnestic response. And this long-term memory effect, so which is advantageous. And it particularly works in children less than 2 years, and therefore pneumococcal vaccines in less than 2 years are always conjugate vaccines. And actually, in Switzerland, they have completely given away those two people, Thomas Neuhaus and Lobe, from the University of Zurich in Switzerland. The entire country has now given up polysaccharide vaccines, and they are fully just on to conjugate vaccines. It's because of the T cell dependent B cell activation. So after having this broad explanation of pneumococcal vaccines, all of you are aware of this. I don't need to go in details that children below 2 years you have to give 2 to 4 doses now of the 13 valent because it's freely available. And children between 2 to 5 years, a conjugate vaccine has to be primed, followed by the polysaccharide vaccine. And older than 5 years, you can do away with a single dose of polysaccharide vaccine. Revaccination is needed every 5 years in a patient who's got active nephrotic syndrome. And varicella is the one which really comes in a lot when we have nephrotic syndrome. So it's important that these children it's a live vaccine again, they need to be vaccinated for a single dose if they are between 1 and 12 years of age. And if there are more than 12 years, 2 doses separated by 1 month. We usually in our clinical practice see a lot of varicella patients in nephrotic syndrome or maybe exposure to varicella. There's a sibling at home who's got varicella, what to do, parents really get worked up. So the protocol that time we follow is within exposure, 96 hours of exposure, we usually give VZIG, varicella zoster immune globulin. And if there are severe clinical symptoms, depending on the severity, either IV or oral acyclovir can be given. These are a few papers on unfounded fears in nephrotic syndrome. They say that vaccination can trigger relapse. As I told you, those 3 vaccines, MMR, hepatitis B, and influenza. An increased relapse rate has been found in these papers mentioned in front of you, but that doesn't negate that we should not be giving these vaccines. It's important that these 3 vaccines should be given because the benefit-risk ratio, the benefit of giving them is much more than the relapse, because relapse can be easily treated with a stress dose of steroids as well. So now we move gears, we come to vaccines and immunosuppression apart from steroids. So anything which we give, any products which are human products, blood, plasma, immunoglobulins, thymoglobulins, whatever, that may contain neutralizing antibodies to the vaccine organisms. Live vaccines again have to be delayed for 6 months. It's a pretty long time, and you need to make sure that this is followed because it's a recommendation. As I mentioned, conjugate vaccines are much more preferred to polysaccharide vaccines because of their greater immunogenicity. I explained you all in the past slides. And ideally, in an immunocompromised patient, we should be checking the protective titers. And if the titers are less for some reason, then increasing either the dose or frequency. I'll come to that. A classic example is of hepatitis B vaccine, where we can also increase the dose or maybe increase the frequency. I'll do that later. Rituximab, we commonly keep giving it. Again, vaccination should be delayed for at least 6 months. And we need to know, all of us, that we are covering this as a nephrology group, but there are many other hemato-oncology colleagues also use a lot of monoclonal antibodies. So all these patients come in the high-risk group, and we need to give them adequate protection at least for these 3. These 3 should be very importantly never forgot: hepatitis B, pneumococcus, and influenza, in addition to the routine vaccines. Coming to seroconversion, as I was telling you, that more important is the immunogenicity, which can be measured by seroconversion. So it is seen that in these patients, it is ideal to use a 4-dose schedule. The normal schedule of hepatitis B for normal children is 0, 1, and 6 months. But here we need to go on a 0, 1, and 2, 12. That's the 4-dose. This is also called accelerated schedule, which I'll be covering in the pre-transplant workup. And actually, there's a quite a bit of overlap because everything is nothing but immunosuppression, and nephrology is nothing but immunosuppression. All of us know that. So either you could do a 4-dose schedule, or you could even double the normal dose. So if you're giving 5 microgram hepatitis B dose in a child less than 10 years, you should give it 10, double 10 micrograms. And if it is 10, you need to go to 20. Patients who are immunosuppressed may not be able to mount the anamnestic response. That's a response which I showed you, the T cell dependent B cell activation. So what we need to do is, particularly for hepatitis B, we need to check the antibody titers, which should be more than 10 milli international units per ml. Actually, I distinctly remember a case here, a pre-transplant child. It was the same child who was malignant FSGS, who was supposed to have a transplant within just 2 months. And surprisingly, they had told me that vaccines are over. Actually, it was my fault. I should have seen it. I just believed him blindly. But when I saw the file just 2 months prior, things were not the way we need to do it. So I had to really run a hepatitis B accelerated dose. So I just had 1.5 month left. So what I did was, there's another accelerated schedule for pre-transplant. It was, gave 0, 1 week, and 3 weeks. That also is recommended pre-transplant if you want to do that. And they were not affording, I know that, but I did an anti-HBS titer and it was again less than 10. So I decided that we should, these patients are immunosuppressed. He was malignant FSGS, proteinuria leaking constantly. So because of that, I think it was, then I realized that best to give double dose. Double dose also works, or the accelerated schedule, either of them work. For current guidelines suggest that the pneumococcal conjugate 13 and the polysaccharide both should be given over 2 years, because it gives you greater sustenance of protection. Okay, I think, yeah. Just to show you these two vaccines, the first one is the triple 3 serotypes which I mentioned, which is routinely available, the influenza vaccine. It has got H1N1 and H1N3. Sorry, H3N2, I'm sorry, H1N1, H3N2, that's the type A influenza and the type B influenza. So there are 3 serotypes in this, which is routinely available. It has inactivated, it's not the intranasal one, because intranasal is live vaccine. You can't give that in immunocompromised. Whereas I think this is more available in the US. These are the quadrivalent. In addition to the 3 serotypes, we also have 2 of influenza B. So this is what is routinely available for our kids. So looking at this table, if you look at the inactivated and the live attenuated, so inactivated, just to summarize, you have to keep repeating doses. If you can do the antibody levels, nothing like it. But for a country like us, it's difficult to do levels again and again. So best is to just give repeated doses. And live vaccines, obviously, we cannot give to immunosuppressed, just to highlight that. Now we move on to the next half of the talk, which is immunization in CKD or ESRD. So 3 issues need to be addressed when we are dealing with such patients. First is, what is the risk of vaccine-preventable diseases in them? Second is the safety, immunogenicity, and clinical efficacy. I said efficacy may be difficult to assess, but immunogenicity, which is nothing but the seroconversion, it's easy. We have quite a few studies on that. And thirdly, the implementation of available recommended guidelines. Just to add to this third point, the Nephrotics in the North America, they had circulated a questionnaire to the pediatric nephrologists, almost 13 to 15 centers all over the North America. And it was seen that pediatric nephrologists really do things differently. Each center was doing differently. So they just wanted to see what the recommended guidelines are and what pediatric nephrologists dealing with immunosuppressed children are doing. Why is CKD an immunocompromised state? Because it really impairs both the T cell and the B cell responses. It could be just because of chronic disease. We know concomitant use of immunosuppressives. These patients mount lower peak antibody titers. That also contributes to this. And there is a more rapid decline, particularly if the patients are on peritoneal dialysis due to loss of immunoglobulins either in the urine or the PD fluid. And otherwise also, usually majority of our patients are nephrotic, so there is also diminished production of immunoglobulins later. This cartoon just shows you that in uremia, both of them are affected, your innate immunity and the adaptive immunity. Because innate immunity is affected, the T cell response and the phagocyte activity is decreased, and in one way it is good, it will give you less inflammation. But it increases your susceptibility to infections, and which in turn can lead to all these things: chronic inflammation, cardiovascular disease, and mortality. I'm sure Roshan will cover that in detail about what the cardiovascular mortality is. And this in turn, all these immune activation can in turn lead to more and more interstitial fibrosis, decrease your residual renal function, and worsen the uremia. And this is just to tell you, whatever we do, even if we do a dialysis procedure, a dialysis access, so all these things at some way or the other, dialysis lines immune activate, pharmacotherapy cause immunosuppression, protein energy wasting also leads to the same. Your dialysis access per se can also cause a lot of infections. We have those line infections. And all these in one way are aggravated by the underlying immune dysfunction which is already present, I told you in the past slide, and all these contributes to your cardiovascular mortality as well. So I think immunization and cardiovascular morbidity are quite related to each other. So The first point is risk of vaccine-preventable diseases. Hepatitis B is now rare in the Western world, but it affects 1/3 of dialyzed children still with us. 50% children post-transplant showed that they developed varicella with significant morbidity. This was very commonly found, and the incidence and severity of varicella was seen to be much lower in immunized children. So the take-home message from here is varicella is very important. We need to make sure that the child pre-transplant is given off this, and it just cannot be missed. Particularly, we see more than 12 years, you have to give 2 doses. And it was seen that measles and influenza were also responsible for significant morbidity, particularly in those countries where measles is sort of given up in the Western world sometimes. Influenza shots are still given everywhere. And particularly in children on PD, Hib and Streptococcus pneumoniae can cause peritonitis. The conclusion from this is, I don't know why they are behaving like that, the slides. Okay. So a low prevalence of these infections is seen among healthy children. That's the good thing. And high immunization rates. So both these things help us in giving a good vaccine preventable disease free things to them. This is about the paper which I was speaking about, Lobby. Second point is about safety. So vaccination in children carries 2 potential risks. One is rejection after the transplant, and second is if you give a live vaccine, it can induce infectious disease after transplant. I'm sure no one will do that, but I'll show you a few examples where people were very bold enough and gave it. Killed vaccines are obviously safe because there's no problem and there is no risk. I don't know why the slides are becoming up and down. Okay, I'll just go slowly, probably. No, I think it's just getting stuck there. Yeah, if you can just see in the background, Kalaivani, what's happening? Yeah. No increased rate of rejection. Yeah, it's okay. I think I just have to press this arrow. That's fine. I can manage it now. It's okay. Don't worry. But it's just getting stuck here. It was seen that killed vaccines have no effect on dialysis efficacy also in patients on HD or PD. So as I told you, most guidelines, or rather every guideline will tell you don't give live vaccines, but 2 studies did give it. This is Zamora et al. It's a good study. They immunized 17 children with varicella, but they found that there was no evidence of rejection or renal failure. So they were lucky enough. Rand et al. Immunized 18 children, but this was after OLT, orthotopic liver transplant, against measles, this vaccination, and there was no complications. Mind well, liver transplant patients have less immunosuppression compared to renal. And Newhas, the person from Switzerland, as I told you, he also was quite bold enough. He reported no adverse effects after a few adolescent transplant patients were given a booster dose of MMR in their routine school vaccination. So this was accidentally happening, but it didn't really have any problem. I don't know, again, it's okay. So as you can see, vaccination in children with CKD and transplant is safe, apart from, because there are many safety issues. Children's parents are very apprehensive, and even the pediatricians are very apprehensive. So we have to tell them, they have to be informed clearly that the vaccines are safe, not to worry, and that there is no evidence that vaccination led to reactivation of any underlying immune process in CKD or maybe in the post-transplant period causing rejection. So all those fears have to be allayed, and vaccination did not aggravate CKD at all, because because of all these fears, these children really don't get vaccines. And I think we as pediatric nephrologists need to communicate with our pediatrician colleagues and tell them what has to be given when. Few papers show about there being a relapse of in nephrotic syndrome, particularly after meningococcal C conjugate vaccine was given. But again, it was just those few reports. But when one such report is published, people really fret over it. But whereas meningococcal C is not really a big problem, but if you use eculizumab, which is still not available in our country, it's a routine vaccine, it has to be given. Okay, I think it's again jumping, but it's fine. I can still manage. Right, coming to the next part is about immunogenicity. So as I said that if you give vaccines in the accelerated form and in a proper dosage or double dose, it does produce detectable and protective antibodies. I'll just go through this. This is about the DT response which was given, though now remember that beyond 7 years, when you're in the adolescent age, we give Tdap, which is the smaller dose of diphtheria and also the acellular pertussis. So there were two barriers to optimal protection. Some children on RRT or post-transplant produce lower antibody titers. This could be, we don't know the reasons, but it is just a chronic immunosuppression because they are not able to seroconvert. So again, you have to just give more doses. And in CKD patients, there's a tendency to wane faster compared to normal. So they wane their antibodies over 6 to 12 months. So again, here comes the role of giving them more doses more frequently, and if you can do antibody levels, nothing like it. And the last thing is about clinical efficacy. As I told you, if a disease is absent, that is the proof, but we really can't rely on that in the population renal because it's less number of children. So these two papers showed that there was a beneficial role of varicella vaccine prior to renal transplant, which I told you varicella has to be in nephrotics, and even post-transplant, you have to make sure that you vaccinate them pre-transplant. And as I told you, that hepatitis B has almost disappeared in these countries with easy availability of vaccine. Not so still with us. And low prevalence rates among patients is related to low prevalence of infections among healthy children and patient siblings in the West. That's what they have seen. What are the only confounders now in vaccination? First is vaccination failure. So despite vaccinating with hip titer and pneumococcal vaccines, some children still develop peritonitis, and we see it's pneumococci growing in the PD fluid. So you just don't know, it may be a different serotype causing that. Oh, okay. So another reason is antibody titers, which are considered to be protective for healthy children. In CKD kids, they may not protect. It's as simple as that. And concentration of specific antibodies in the PD fluid may not be sufficient. And third reason, it could be just that it's a different serotype. And we all of us are again and again speaking about the low herd immunity, which I told you there's re-emergence of measles now in the West because of the decreased vaccination in the general population. So at least in India, we are not having this problem because the herd immunity is still good, because we are still having these vaccines given to all our children. And I'll just quickly run through this immunization. The flip side of this is that, I mean, when you are looking at a CKD child or a pre-transplant child, it's a multidisciplinary team. And usually vaccinations are thought as minor problems, but it is not actually, because I think as a pediatric nephrologist, our roles comes here and we need to address that issue importantly. Parents and patients sometimes perceive an associated risk when they read in papers that measles was related to autism or IBD, hepatitis B with multiple sclerosis. I think this is more for problems in the West, but though we have a technology population in India is growing as well, so they do read newspapers and find out. So we need to explain them that though some vaccines can cause these problems, but your child is very different because it's CKD and will be transplanted soon. And this fear has to be completely allayed that it will cause any rejection of the renal graft. And the good side of it is that household contacts are also vaccinated, which gives a very good herd immunity to the CKD child. I think this is not just IAP recommended slide, which I just wanted to show that this is what we use. And last few slides about immunization for transplant. If you're running out of time before the transplant, it's best that you should be counseling the parent, introduce early vaccination, go through their charts and repeat vaccinations. If you can do a titers, again, well and good. Killed or component vaccines can be safely administered even after transplant, but I think it's important that we give everything pre-transplant. And these two unresolved issues are still there post-transplant, whether we can give live vaccines. And one more important thing is immune memory. When we give a child so much of transplant immunosuppression, so post-transplant, if you give any vaccine, the seroconversion is very, very poor. So particularly in the first 2 to 3 months when the immunosuppression is at a very high dosage. So such patients even don't seroconvert. So there is really no point giving even a killed vaccine. It may really not seroconvert. And this is about a child who's awaiting transplant now. So a transplant candidate is more immunocompetent than obviously a post-transplant patient. So every effort should be taken to initiate and complete the schedule fast. As I was mentioning, you have to have shortened intervals and the vaccine doses can be doubled up. the protection wanes off due to post-transplant. This is another factor showed in this paper, as I was speaking about just before, that your post-transplant immunosuppression will wane off the antibodies. So there's no point giving them post-transplant anything. And as a general rule, we need to know, again, the 6 months target is coming here. Any vaccine after 6 months post-transplant is not recommended, neither live nor killed. Pre-transplant period, at least 1 month prior, we should make sure that there's a 1 month free gap, and before that all the vaccines have been covered. If vaccination is incomplete or missed, particularly an example is given, if you haven't given polio, then the best is to try IPV, and now IPV in the general pediatric world also is very routinely used, so we can do that. And MMR vaccines and varicella really have no alternatives of inactivated form. So as I said, I showed you that these vaccines in small studies have been given post-transplant, but still data are not sufficient to recommend them as routine alternatives. And this is the slide which I wanted to show you, that on this side is the minimum expected number of doses pre-transplant, and this is accelerated schedule. So if I just want to draw your attention here to hepatitis B, at least 3 doses need to be given, and you can even, as I told you, I have used this schedule myself, so I know it works. 3 doses given at day 0, day 7, and day 21. So 0, 1 week, and 3 weeks. You can just finish off your hepatitis B if it's not been given, or if you find the antibody titers are low, which I found in that patient. The others usually recommend 4 to 6 weeks gap, the standard gaps between those doses. So further studies are needed for post-transplant vaccines, and the benefit versus risk is more in areas of low herd immunity. So it's important that we need to have routine immunization programs for household contacts. I'll be covering in the next few slides about that. And healthy pediatric vaccinees have a good immune memory, and they really don't require boosters compared to CKD kids who really need to have more boosters. This is still open to debate. Many papers are still not on that. The last 2 slides about immunization of household contacts. It's important that you should vaccine a child, particularly for influenza and pertussis, because the source of the infection can come from another family member. So these shots, annual influenza shots, I think need to be given. Particularly remember, not the intranasal, because that is live. You have to give the inactivated ones. This is to help you develop herd immunity. Inactivated vaccines to influenza, hepatitis B, and pertussis can be safely given. Why is it mentioned twice again? Because there are, these are the only 2 absolute contraindications. You should not be giving these 2 these 2 vaccines to the siblings, the oral rotavirus and the OPV. OPV can be substituted for IPV. Why? Because these can be transmitted to the immunosuppressed child. And obviously, immunization of a household contact with varicella vaccine is essential, though it poses a low risk, but this risk, as I told you again and again, is greatly outweighed by the benefits. So it's important to give these. And this is about vaccinations for travel. This is the last slide. I had 2 other slides, but for some reason I could not put it up, but that doesn't matter. You know, if a child, we should not, particularly the COVID times, we should not be traveling, but before that children were traveling. So particularly if you're going to a high-risk endemic area, a few vaccines are important. And all these have counterparts in the inactivated form. So we know there's inactivated typhoid, which is Typhi IM, not the oral one, the Japanese encephalitis, and even the cholera. The live vaccines, such as these ones which I mentioned, are contraindicated. And although efficacy among healthy subjects has been studied, as I told you, there are many efficacy studies, but for immunosuppressed RT recipients, it's very scarce. Therefore, every effort should be taken to adhere to hygienic practices. Prevention is better than cure. Try to avoid the exposure in the first instance. So I would just like to complete here with the few take-home messages. So take the earliest opportunity when you see the child and immunize them, tell them, inform them about their vaccinations. Use accelerated schedules as much as you can. Avoid live vaccines in the immunosuppressed. As we said, anything more than 2 mg per kg or 20 mg daily. Some books even mention alternate day 20 mg. This for more than 2 weeks is absolutely contraindicated. Child on other immunosuppressants you can't give. Inactivated vaccines are very safe. And these three, hepatitis B, pneumococcus, and influenza, again and again, I'm saying in nephrotics and CKD, we need to, because pneumococcus is usually missed sometimes in CKD patients and influenza as well. In the transplant recipients, all vaccines are generally contraindicated during the first 6 months, I must say, not even 3. And household contacts should be receiving all the standard immunizations, including the non-transmissible live vaccines, which is MMR and varicella, but not the transmissible ones, which is polio and rota, and we can use the IPV instead of oral for that. A big thank you. I'm sorry I was a bit prolonged, more than 5-6 minutes. Thank you for the patient hearing.
Thank you, Dr. Manoj, for the elusive talk on immunization in CKD and in nephrotic syndrome.
Yeah, so should I move on to the introduction of the next speaker?
Yeah.
Should I do that?
Yeah.
Okay.
Yeah.
Thank you. Yeah. Yeah. So incidentally, Kalaivani wanted me to be the moderator, so it's good pleasure for that. No worries. So I'll be introducing the next speaker now. I hope you all can see the slide. Oh, sorry, it's just still thank you slide. Just a moment. Can you see the slide? Kalaivani, just tell me.
Yeah, I am able to see.
Okay, fine. So we have with us another speaker, a very dear friend, Dr. Priya Pais from Bangalore. She is a diplomat of the American Board of Pediatrics and Pediatric Nephrology, and currently working as an associate professor at St. John's Medical College. Her specific interests are in pediatric hypertension and ambulatory blood pressure monitoring, which she'll be covering for us today. And also she has interest in outcomes research in CKD and dialysis and bioethics. Her roles are currently, she's the coordinator of the ABPM program at St. John's. She's the convener of the Hospital Ethics Committee and Human Research Participant Protection Board. And she's also the regional representative of our society, the Indian Society of Pediatric Nephrology. And she indeed is a member of the IPNA Sister Renal Center and IPTA. IPTA is the International Pediatric Transplant Association Outreach Committees. So I'm sure we'll have a wonderful talk from her. So with this, over to you, Dr. Priya Pais. Thank you.
Thank you, Dr. Manoj. I'm going to be opening my slides now. Hello?
Yeah, we can hear you.
No, the screen
Slides
has just disappeared. I'm not sure why.
It's there in the left-hand side bottom, IPNA ABPM final.
No, just give me 1 second. My screen was fine until a minute ago.
Maybe you just refresh and re-log in. Sometimes it just gets hung up, probably.
You're there in the open presentation view, ma'am.
No, actually, the screen just...
Can I open the slides for you? Can I open the slides for you? Your slides are visible for me.
No, you please open them, but I don't see anything. Can you see me?
Yeah, we can see you.
Like, I have opened your slides. Is that visible for you now?
No, it's not actually. I was able to see my intro slide. I don't know why, what happened.
I think we can hear you, but you want to re-log in. Maybe that will just clear the hang-up issues. You can't see anything, right?
I can't see anything, actually. So,
you just re-log in.
Dr. Priya Pais slide. I'm able to visualize the slides.
Why don't you move ahead? I'm not sure if it's something wrong with my laptop all of a sudden.
Okay, no problem. So what I suggest is, Priya, what you can do is you can, no worries.
Yeah.
Kalaivani, what we'll do is, Okay, sorry. So we'll just go on to Roshan's talk, and then maybe once she relogs in, then we can take. Is that okay, Kalaivani?
Yeah, that's fine. That's perfect.
Okay, fine. Yeah. So thank you, guys. Sorry, guys, for this technical glitches. We always have it in an online webinar. So let me just move on to another very important speaker. She's an international speaker. I know her very well. We met her 6 months ago at CMC Vellore. A beautiful speaker as well again. Let me just go on to her introduction slide. Yeah, so just give me a hands up. Kalaivani, can you see the slide?
Yeah.
Okay,
Yeah.
thank you. Perfect. So this is Dr. Roshan George. She is an MD and also fellow of American Society of Transplant. Currently, she is the associate professor in the Division of Pediatric Nephrology at the Emory University and Children's Healthcare at Atlanta. And she also is the program director there for the fellowship and director also of the Transplant Quality and the Solid Organ Transplant Society. Her specific academic interests are transition of care, biomarkers for detection of early rejection in transplant, social determinants of health and healthcare disparities, and quality improvement in medical education. She has got a lot of awards. Let me just list out them for you. She's got Excellence in Patient Satisfaction Award from the Emory University. She's been designated as the Fellow of AST 2019. She's the Chair and the Education Subcommittee for Pediatric Community Practice in the AST again. And she's also the regional representative for the UNOS, which is a organ sharing network and transplantation network as well, from July 19 to June 22. And lastly, she's the co-chair of and the member of the member education committee of American Society of Pediatric Nephrology from this year September for 3 years. So that's beautiful to know that you've just got this year. So over to you, Dr. Roshan George, for your presentation. Thank you.
Thank you so much for the introduction. Can you hear me?
Yeah.
Yes, we can hear you. Go ahead, yeah.
You can see my slide?
Yes, we can indeed, yeah.
Okay, that's wonderful. Yeah. That helps my cardiovascular health. So I'll start by thanking everybody, especially the organizers, and especially Dr. Kalaivani for giving me this opportunity to present this talk. I'm going to talk today about cardiovascular health in chronic kidney disease and how do we protect our patients. So I have no disclosures, and the objectives today that I'm hoping to meet is by the end of this talk, we should be able to know the impact of pediatric CKD on cardiovascular health of our patients, elaborate the pathophysiology of chronic kidney disease, which causes this cardiovascular disease, and know some practical ways to reduce risk and prevent cardiovascular disease in CKD. So this is a vast problem in our population because long-term survival of children with CKD is lower. In fact, a patient who has end-stage kidney disease in pediatrics has a 30 times increased risk of death. And if we look at just cardiac death as a cause, this risk is 700 folds higher. In the US, when we compare the children who are on dialysis, their lifespan when compared to age and race matched population is reduced by 40 to 60 years. And even after transplantation, this is better, but it's still reduced by 20 to 25 years when compared to age and race matched controls. And for this cause of death, cardiovascular mortality is the most leading cause in pediatric CKD. This was so recognized as a high risk that AHA, American Heart Association guidelines for cardiovascular risk reduction in 2006 actually put CKD patients as a high-risk stratification along with patients who had type 1 diabetes mellitus, heart transplant, familial hypercholesterolemia, and coronary artery disease due to Kawasaki disease. So this is important to remember that our pediatric CKD patients are in that high-risk category, along with several of these conditions which are really limited in numbers. So when we look at leading cause of death in the general population and compare it with our chronic kidney disease patients, we'll see that this data, which was taken from USRDS 2011, shows that the general population, the cardio death is 3%, which is really a very small cause of other causes of death, and is below here as number 5 in this list, but truly not very significant. But our PD patients and our hemodialysis patients, cardiac cause of death is the leading cause, 28 and 32%. And even after transplantation, it improves, but it's still the second major cause of death in our population. Within that dialysis and transplant group, causes of cardiac death in this age group 0 to 19 years is most commonly because of cardiac arrest or arrhythmias. You can also have cerebrovascular disease, and in dialysis patients, we'll see congestive heart failure or pulmonary edema. And in transplant patients, the third most common is because of acute myocardial infarction. Cardiomyopathy is also there in both, and then acute MI comes in dialysis a little bit lower down the list, and pericarditis is also a cause there. In general, when we talk about risk factors for cardiovascular disease, there are traditional risk factors, and then there are uremia-related or non-traditional risk factors. So traditional risk factors, as we know, hypertension, dyslipidemia, obesity or sedentary lifestyle, hyperglycemia or insulin resistance. And there are other factors of which I've listed smoking here, and in adults, obviously, that's a huge risk, but it's still important to remember that in pediatrics, it's much lower, but it's not zero. We have adolescent patients who do indulge in this. So that traditional risk factors as a category is there, but then our patients also have, in addition, uremia-related risk factors, where anemia, hyperparathyroidism, increased calcium phosphorus products, and other abnormalities of mineral metabolism, increased C-reactive protein or inflammation, and hypoalbuminemia or malnutrition is associated with that. We should also point out here that there is a high prevalence of traditional cardiovascular risk factors in patients who are already experiencing uremia-related risk factors. So it's an amalgamation of all these different risk factors that our patients are susceptible to, which increases further their cardiovascular risk. And we have some genetic factors and a lot of environmental factors and factors related to their dialysis and complications from dialysis. So let's get into these factors one by one. Hypertension is quite frequent, and several studies have shown that over half of our patient population, even in early pediatric CKD, with even medications, have high blood pressure. And I'll point out to a study that was done recently on this. Dyslipidemia, mainly we are focusing on increase in triglycerides, total cholesterol, LDL, and low HDL. Obesity and sedentary lifestyle in itself can be an independent risk factor, and I'll give you a little bit more information on that in next slide. And this has been shown that there are lower levels of physical activity and reduced aerobic capacity in our CKD patients, and this is supposed to get better after transplant, but still is not as improved as in normal population. Abnormal glucose metabolism is also another thing we need to keep in mind. There is hyperinsulinemia in about a third of our patients, and insulin resistance in 16% of CKD 2 and 4 patients, including in our dialysis population. And as I mentioned before, important to get the history about smoking. So in children, adiposity is independently associated with markers of cardiac damage. This was a study that was published in recently in AJKD, which looked at 725 patients from the CKID database. And these are from multi-center patients in North America. And they divided patients into, based on their BMI, normal, overweight, or obese patients. The normal patients, if we look at the male population, had about a 6.1% higher left ventricular hypertrophy was present in 6.1% of those patients. And in the boys, the difference was not very profound when you compared overweight and obese patients. Everything was less than 10%. But moving on to female patients with CKD, we see that normal weight patients or normal BMI patients, left ventricular hypertrophy was present in about 8.4%, but in patients who were obese, the left ventricular hypertrophy rates went up to 33.7%. And this scatter plot here basically looks at age, sex-specific BMI z-scores with age, sex-specific left ventricular mass index z-scores. And what this showed was that for every 1 unit increase in BMI, for girls in the population, the LBMI z-score increased by 0.4, and for boys increased by 0.2. However, when multivariable analysis was done, there was a 3-fold higher increase or 3-fold greater risk of LVH in female patients when compared to male patients and the general population for increased LVH. So in and itself, adiposity was independently associated with cardiac damage. One thing to remember though is that, LVH, LVMI are good markers for chronic, for in these patients for cardiovascular disease, but they are not hardcore endpoints in itself, but still amongst what we have to detect early cardiac dysfunction, these are good markers. So these studies kind of show that obesity can be something that is one of the modifiable factors in this population. Now moving on to our uremia-related or non-traditional risk factors, volume overload is something that we struggle with in patients who are on dialysis, especially if there is a failure to achieve true dry weight or intradialytic weight gain with dialysis. These patients also have anemia even with availability of erythropoietin-stimulating agents. You can see patients, about a third have some degree of anemia once they have CKD. Abnormal mineral metabolism is a huge risk factor secondary to hyperparathyroidism, nutritional vitamin D deficiency, and high levels of phosphorus in itself. And I'll talk a little bit more about this shortly. Malnutrition, and also inflammation and immune dysfunction, which is exacerbated by malnutrition. With inflammation, there's release of cytokines, increased production and activity of adhesin molecules, and T-cell adhesion attracting pro-fibrotic factors, worsening your uremia-related risk factors. So at what level of GFR do these risk factors start happening, and when do we need to start monitoring and mitigating some of them? So this study was done using again CKD population and published in 2011. And as you can see, as I had mentioned, anemia is present even when CKD is not significantly worsening GFR. These are patients with GFR over 50, and we have these other groups with GFR 40 to 50, and the worst or the largest population of anemia is in patients with GFR less than 30. And these are all patients who are showing up at centers who have insurance and access to nephrology care. What I want to focus also on here is that even with availability of care, about 14% of the patients had systolic hypertension and 13% had diastolic hypertension within this CKD cohort. So this happens quite early, and the risk factors are present even when the GFR is not significantly low. Another point to note here is that compared to norms, our chronic kidney disease patients also have a stronger family history of cardiovascular disease, hypertension, hypercholesterolemia, and diabetes. So the traditional risk factors are further exacerbating the uremia-related risk factors. So moving on to the cardiovascular findings that are there in CKD, we see that there is large effects on the left ventricular structure and function. That is one of the findings. And the other major finding is effects on the large vessel that we see. And if we go back a little bit more and look at the pathophysiology, this is secondary to increased sympathetic tone, increased salt sensitivity, and upregulation of the renin-aldosterone-angiotensin system, which causes these two effects of abnormalities in the large vessels and in the left ventricular structure, and primarily leading from hypertension. So moving a little bit more into the details of these findings. So the major two findings, as we mentioned, left ventricular dysfunction and large vessel disease. If you look at left ventricular dysfunction, and I would go a little bit into this, but not into too much depth because I'm not pretending to be a cardiologist here. We see that there is left ventricular mass and relative wall thickness. And in normal patients, both of these are normal, the left ventricular mass index and relative wall thickness. However, when you have eccentric hypertrophy, which is caused by volume overload, you will see that the left ventricular mass index is increased. However, the relative wall thickness stays the same. When there is concentric remodeling, the left ventricular mass index stays normal, but your relative wall thickness has increased. When you have concentric hypertrophy now, you have increase in both of those, the left ventricular thickness as well as left ventricular mass index. So when we compare this eccentric and concentric hypertrophy, we see that there's two different reasons behind them. The eccentric hypertrophy is secondary to volume overload, which causes, again, like we mentioned, increased LVM or left ventricular mass index, but normal right ventricle, the relative wall thickness. Whereas in concentric hypertrophy, the pressure overload is the main cause for this, causing increase in both left ventricular mass and increase in the relative wall thickness. Moving on to the large vessel disease, we know that CKD ends up affecting multiple areas of this cross-section of the large vessel. You have problems with endothelial function, increased carotid intimal media thickness, and finally coronary calcification. Leading to frank atherosclerosis. So let's look a little bit more on how we would analyze this. And just again, briefly to mention that diastolic dysfunction is something that is initial functional abnormality that is seen in the left ventricle. And this is a little bit different compared to adults, because this also initially seen in adult patients, but in adults, the systolic dysfunction is a little bit more obvious or overt. So in our pediatric CKD population, diastolic dysfunction is the initial finding. And there are two ways of measuring this. You can measure it by using the mitral inflow using Doppler. And this is a ratio that is used, which is E by A ratio. And E is early diastolic filling, and that you can see the first peak up here, and the A is atrial kick, which is a smaller peak, but that ratio in normal patients should be more than 0.8. This can be affected by hypervolemia. So in a dialysis patient who we are not able to achieve dry weight, this may not be the best test. So tissue Doppler is utilized, which is a little bit better. And here we are looking at E prime by A prime, which is again the same kind of ratio, looking at early diastolic filling and the atrial kick, but it is looking at the septal annulus to determine this, and normal is more than 8. Why I'm trying to say this is that you may not find initially LVH, but these Doppler studies are even an earlier marker. And children on dialysis have worse diastolic dysfunction. Not to forget about systolic dysfunction, because even though in adults they present early with overt systolic abnormalities, in pediatric patients, studies have shown that subclinical systolic dysfunction is present in up to 40% of hemodialysis patients. And it is better identified by using mid-wall shortening fraction compared to endocardial shortening fraction, because it will give a more accurate estimate. So once we actually have a left ventricular dysfunction, we see that diastolic dysfunction is more common and present early. Moving on to the large vessel disease, there are risk factors that cause an increased prevalence of this, such as longer duration of dialysis, greater calcium phosphorus product, increased cumulative dose of calcium-based phosphate binders, and also specifically calcitriol or activated vitamin D. And these known abnormalities that I had mentioned before are present. So just diving a little bit into these abnormalities and seeing if we can find some pathophysiologic basis for some future treatments. So starting with our abnormal endothelial function. So this was a study that looked at nitric oxide done by one of my colleagues here at Emory. We all know that nitric oxide acts on the smooth muscles and causes some vascular relaxation. And in normally functioning kidney, there is de novo synthesis of arginine, which is converted into nitric oxide. Also, the kidney removes ADMA, which is asymmetric dimethyl arginine, which is an inhibitor of nitric oxide synthase. So if there is more ADMA, the nitric oxide synthase will not act and arginine will not be converted to nitric oxide. So in a normal kidney, which clears ADMA and produces arginine, there is sufficient nitric oxide to cause normal smooth muscle relaxation. However, in CKD, there's not enough arginine. The ADMA is not cleared, so the nitric oxide synthase is not acting because of this inhibition. And this pathway gets activated, as shown by Dr. Reyes, that arginine gets converted through arginase into ornithine, which even worsens your cell proliferation and remodeling. And reduction in the nitric oxide reduces vascular relaxation in CKD patients. There's also studies that looked at endothelial dysfunction specifically, and in addition to this reduced nitric oxide availability, uremic toxins and inflammation in itself reduces the repair, and there is release of procoagulating factors, and reduced EPC, which is endothelial progenitor cell survival, leading to basically endothelial cell detachment as a starting point of our vascular abnormalities. So going further ahead, looking at carotid intimal media thickness, which is more of a marker for vascular disease. This was a study that was done in 2012, looking at children, again, using CKID database. And they looked at carotid intimal media thickness for patients. The GFR, the median was around in the 50s in these patients, and use normal controls. And the median here is different between these. And even though in values 0.43 and 0.41 seem kind of close, this was significantly different in these patients. And even more concerning was that as they went up into percentiles, by the time you reached to 95th percentile, there was significant difference between the control population and CKD population. And this marker of carotid intimal media thickness is a valid marker for cardiovascular disease. So we know there is abnormal endothelial function and increased carotid intimal media thickness in pediatric population, even with early CKD. What about coronary calcification and frank atherosclerosis? Some of the mechanisms underlying this are very familiar to us. Promoters of calcification, the calcium phosphorus product, increased PTH, are there in these patients. Increased phosphorus by itself is a promoter of this vasculature, the vascular smooth muscles, to convert to osteogenic forms. So there is osteogenic conversion, there is deposition of hydroxyapatite crystals, and gradually within that tunica media and surrounding areas, there is deposition of these and conversion of the smooth muscle cells into osteogenic cells causes more apoptosis and deposition of collagen fibers in here. So one of the big problems, which is increased phosphorus levels and increased calcium phosphorus product, is an area to target for prevention of this. So we know again early on that we have basically abnormalities all through the vasculature in these patients. Going to the next big cause, which is now more under study, is immune dysfunction in chronic kidney disease. And as Dr. Manoj also pointed out, you have loss of T cell abnormal function. So this was a study that I had done in CKD population, looking at about 80 kids and 20 normal controls. And we found that children on dialysis had an increased high sensitivity CRP, and also their immune cells, their T cells specifically, were skewed towards exhaustion and senescence. So CD28 and CD57 markers were increased. The CD28 negative T cells were increased in both dialysis and CKD population, and CD57 was also increased in this population as compared to normal controls, and both of these are markers of exhaustion and senescence. And it has been shown in patients with these memory T cells being increased that there is higher risk for cardiovascular disease. Working more on that premise, one of my colleagues did some basic science research and found that in 5/6 nephrectomy model of CKD, there was uremic cardiomyopathy with increased PD1 and KLRG1 genes, and actually increased T cell in CKD myocardium. When these mice were given anti-CD3 antibodies, which depleted the T cells, there was improvement in the heart diastolic function, and there was improvement in ventricular strain. In this same paper, we showed that the earlier population I had talked about, looking at their echoes a few years later, we found that patients who had higher PD1 and CD57 actually also had markers of diastolic dysfunction in their echoes. So both animal or mice study and human studies kind of show early onset cardiac disease related to their inflammation and T cell dysfunction. There are some differences in adults and pediatric cardiovascular disease with CKD, but also some similarities in that diastolic dysfunction is kind of common in both populations early. However, as I had mentioned, the adult CKD, it's more overt systolic dysfunction, which is not initially seen in pediatric CKD. LVH develops early in both adults and pediatrics. The big difference is where the calcification occurs in the arterial wall, because in adults you see both intimal and medial calcification. Parts of the causes of intimal calcification are related to age and other risk factors such as LDL, being high, and smoking. Whereas in pediatrics, you see medial calcification, which is diffuse and non-occlusive more commonly. Other such symptomatic coronary artery disease, MI, cerebrovascular accidents are rarer in pediatric CKD. So what ends up happening is this vicious cycle where the renal disease perpetuates all these abnormal uremic risk factors, which worsen the cardiac disease, and worsened cardiac disease causes poor perfusion, worsening inflammation, more endothelial dysfunction, and worsens your renal disease, making this cycle of dysfunction between chronic renocardiac syndrome and chronic cardiorenal syndrome. So what can we do about this? We have to manage all the risk factors that we can manage in these patients, and managing traditional risk factors is something we have been doing for other patients, and many of us are well versed in managing the uremia-related risk factors. But just to point out that of everything, transplant is a way to reduce the cardiovascular risk factors in these patients. But as I showed in my beginning slides, it does not totally eliminate these risk factors because once you have started having that diastolic dysfunction and abnormal metabolism, it's not very easily reversible. So moving on to managing hypertension, ACE inhibitors or angiotensin receptor blockers are a good starting point for managing hypertension. Management of volume overload, optimizing dialysis, increasing either the frequency or the time if you're doing PD, diligent monitoring of ABPM, which we'll hear more from Dr. Pais soon. Echoes, there are different guidelines. Once annually at least is recommended if we need to look at some of these patients with CKD that is further along. Managing anemia, managing abnormal mineral metabolism, which I'll talk more in the next slide, managing dyslipidemia. This is something where more studies are needed. Statin therapy for LDL over 130 in patients over 8 years has been noted in some papers. We have to remember, as I had pointed out earlier, that AHA has classified CKD patients in that high-risk category, along with heart transplant patients, and many cardiologists begin statin therapy in heart transplant patients in pediatric age less than 8 years. So this is kind of the thought process behind starting statin therapy. But definitely dietary management is something that we can all recommend for these patients. Encouraging active, healthy lifestyles, reducing weight, and also making sure that there is no other risk factors such as smoking in some of our adolescent or older population. Going back to managing abnormal mineral metabolism, this is really key, as each one of these risk factors in and itself can exacerbate the cardiac dysfunction. So if there's increased phosphorus level, obviously we want to reduce the dietary phosphorus intake. We want to, as much as possible, administer calcium-free phosphinders, and also consider intensified dialysis. If we see that there's increased cumulative intake of calcitriol, that is something that also needs to be looked at, and again, a way to avoid high calcium phosphorus product. If there's signs of tertiary hyperparathyroidism with increased intact PTH or increased calcium in the serum, consider parathyroidectomy, either surgical or by using Cinacalcet or medical means. All of the above can also be reduced by using transplantation as a treatment strategy if that is feasible. But important to make sure that we are monitoring for this. Vitamin D and its analogs, this is native vitamin D like cholecalciferol. There have been reports that it has several other actions on our cells, especially on the renin-angiotensin system, being as a negative regulator, exerting some anti-proliferative effects on the myocardial cell hypertrophy, and also inhibiting some aspects of inflammation. But more rigorous studies are needed on this. As much as possible, we can monitor and get the vitamin D, the native vitamin D level within normal ranges. Patient education here is key. We really have to partner with our patients, because we can give them all these recommendations, but until there is buy-in from them and shared decision-making and understanding why this is important, and sometimes as much as we love our kidneys and we know that kidney health is truly important, bringing the heart into the conversation helps them get on track. So lowering dietary sodium, blood pressure control, exercise, weight loss, and monitoring and following recommendations. Finally, I'll come to say that there are several studies that look at CKD, and this is prevalent all over the world. We have incidence increasing in countries, but it's important to also have registries and maintain data on these patients so we can actually have long-term follow-up, because most of these guidance or risk mitigation strategies are issued or discussed, but we don't have long-term data and studies that show how this has actually helped patients by giving concrete outcome results. So in conclusion, CKD has impact on cardiovascular health early and before even GFR is significantly reduced, definitely even before they get on dialysis. Pathophysiology is complex, and there are several interrelated factors that affect each other. Early diagnosis and reduction of risk factor can improve cardiovascular health in these patients. So it's important on our end to start the strategies for risk reduction and monitoring early and getting the patients to understand that. And future studies with better risk stratification, targeted treatment, and long-term follow-up are needed. So in 2011, World Kidney Day had this motto they had adopted, this protect your kidneys, save your heart. And so I'll end by saying that, almost 10 years down the line, this still remains true, and we do need to do a lot more to help our kidneys to protect the rest of our body. So with that, I finish my talk, and I will let you go back to Dr. Manoj.
Yeah, thank you. Thanks, Dr. George. It was indeed a comprehensive coverage of the cardiovascular outcomes in CKD. Thank you so much. It was an excellent. So now we move on to the next speaker, Dr. Priya Pais. I'm sure we can see you. Yeah. So Priya, you can go ahead. We can't hear you.
Can you hear me now?
Yes, now we are. Yeah, thanks.
Okay. So I'm going to give, do you see my slides?
Yes, we can see your slides.
Okay, great. So thank you for the introduction earlier, Dr. Manoj, and thank you, Dr. Namalwar and Dr. Kalaivani for organizing this webinar series, especially to Dr. Kalaivani for doing all the organization. I'm going to speak about ambulatory blood pressure monitoring in children, its indications, its interpretation and significance. And this talk will not focus solely on chronic kidney disease, but more on ABPM in general, as it applies to pediatrics. So as we've been hearing, hypertension is one of the strongest modifiable risk factors for cardiovascular disease worldwide. This graph is adapted from the Lancet Commission on Hypertension, and they call it the life course approach. So of course, ideally, we should all be following the green path, where we have very little cardiovascular disease. On the y-axis is a person who goes from being healthy to a person who develops overt cardiovascular disease and all that it entails. And on the x-axis, we have age increasing. So although most of us will follow the blue path, we note in this graph that in childhood, everybody looks like they're healthy, but in fact, there are cardiovascular risk factors that begin very early in childhood as well as in adolescence. And this has been shown in the Bogalusa heart study and several other studies looking at cardiovascular risk factors in early onset. And there is a subgroup of high-risk individuals who are on that red curve, where the onset of risk factors, specifically hypertension, starts in childhood and early adulthood, and these are the ones who go on to develop overt cardiovascular disease in early middle age. And so, therefore, the find that cardiovascular risk factors really lead to early vascular aging. Now, we also know that 80% of the global cardiovascular mortality, not the morbidity per se, but the mortality, occurs in low and low middle income countries like ours. So therefore, our goal would be to maintain normal blood pressure throughout life. Some of the action statements put forward by the Lancet Commission include a better quality of blood pressure measurements, better identification of those high risk for hypertension and high risk of secondary hypertension, and to monitor those on treatment and respond by adjusting their medications. And we'll see in this talk how ambulatory blood pressure monitoring actually will play a role in all these actions. So we'll cover briefly the utility of ambulatory blood pressure monitoring, some practical aspects on monitor placement and interpretation. We'll discuss the clinical significance of pediatric ABPM and round it out with some experiences of ABPM in India, and finally conclude with the cost effectiveness and some caveats to keep in mind while doing ABPM. So what is ambulatory blood pressure monitoring? I'm sure you're all familiar that an ABP monitor is a portable device that is attached to a cuff that is worn on the child's arm. And this device usually measures an oscillometric blood pressure automatically every 20 to 30 minutes throughout the day and night. And when the monitor is returned, this data can be downloaded to a computer for analysis. This picture is actually one of our dialysis patients who's wearing an ABPM monitor. So what are the advantages of ABPM over office blood pressure? Of course, it provides a much larger number of readings. If we do get readings every 20 to 30 minutes, then we expect readings that are about 60 to 70 in 24 hours. It also provides blood pressures obtained in a real-world environment away from the anxiety-inducing hospital environment. It provides valuable information on overall blood pressures, as well as separated into blood pressures that occur in the day and the night. And only ambulatory BP monitoring can identify the phenomenon of white coat hypertension, masked hypertension, hypertension occurring only at night, and also describe the variation that occurs from day to night, as described in the nocturnal dip. And we'll discuss these more in detail as we go along. It's also very useful to look at how our antihypertensive medication regimen is working. So ABPM is well studied in adults. It has been studied for over probably around 35 to 40 years. And the AHA, the European Society of Hypertension, and the NICE guidelines all endorse its use. Its methodology is validated, it's feasible, we'll go back one slide. It's been shown that both the mean blood pressure and a blunted nocturnal dip on ABPM predict actual hard cardiovascular events better than clinic blood pressure. And therefore, it's recommended for the diagnosis of hypertension. It's also known to predict progression of CKD. So what about ABPM in children? We do have monitors validated for children. It's feasible mostly in children 5 years and older. There's a question mark as to whether ABPM predicts hard cardiovascular outcomes because there is simply no data. But we do know that ABPM predicts cardiovascular surrogate markers in children, such as left ventricular hypertrophy and arterial stiffness. And therefore, we have the AAP guidelines, Canadian hypertension guidelines, and the European Society all recommend ABPM for the diagnosis and management of hypertension in children. So moving on into ABPM placement and interpretation. So first of all, this is just a representative sample of the ABPM machines that are available. There is quite a wide variety. And there is no particular brand that is better than others, as long as, if you look at the underlined line in the table, as long as they are clinically validated. And if they're clinically validated, then they should be appropriate for use in children, and the validation is specific for pediatrics. How do we know whether our machine that we're considering investing in is validated? There's a website called Dabble Educational, which is a non-profit organization that validates all kinds of blood pressure devices. And so if we look up under ambulatory BP monitoring devices, the column on the rightmost tells us whether the machine in question is recommended or it's a little bit in doubt. And the way that they validate it is based on protocols put forth by the British Hypertension Society, the Association for Advancement of Medical Instrumentation, and the European Society for Hypertension. And if the grading is adequate, then they say the machine has passed the validation test. So we at our center use space labs, and so therefore this is a representative picture of all the equipment that comes with running an ABPM program. Of course, we need a variety of different ambulatory BP monitoring cuffs, similar to a clinic BP. There is the monitor itself, a tubing that runs from the monitor to the cuff, a case, a patient diary, and a belt. Placing the ambulatory BP monitor is crucial to be done correctly. And as in a clinic BP, we start with measuring the mid-arm circumference, which is done in the standard way. Once the mid-arm circumference has been measured, we choose a cuff Each cuff has a size range marked on it, and so the mid-arm circumference must fall within that range. Once we've done the measurement for the adequate, appropriate cuff size, then it's important to measure a clinic auscultatory BP, because this will help us classify the ABP staging of blood pressure. Once you've done a clinic BP, we apply the ABPM cuff to the non-dominant arm, tight enough that it stays on and doesn't slip off, but loose enough to allow our fingers so the child is not uncomfortable. There are very few practical contraindications to doing an ABPM study. This is a gentleman, not a child, but it basically shows for our scenario where very few children actually wear belts, that this is an alternative setup for sort of a shoulder harness or a little handbag type approach, and this is the way we actually place our ABPM monitors for most of our patients. We initialize the monitor, that is, we program it to take a blood pressure every 20 minutes during the day. We actually program our machines to also do it every 20 minutes during the night, and we have not had any complaints about disturbed sleep. It's important to set up the monitor on the patient securely because the monitor shouldn't fall and break. And we do take trial blood pressure values in the clinic to demonstrate to the patient what it feels like, what it sounds like, and to also advise them and show them how to keep their arms still during readings, because we really don't want the patient moving because it will lead to a lot of missed readings. So a brief description of our program. We have 2 space lab machines that we have, and we have an ABPM nurse who's also a dialysis nurse who places it, so that is really very helpful. We give each patient a patient diary and ask them to note down sleep-wake times, basic activity periods, and any medications that they take. Educating the family is very important. We need to tell them to avoid getting the machine wet, damaging it, or indulging in vigorous activity during the monitoring period. For practical purposes, all patients come to our center to have the machine placed, and then we expect them to remain in the city for 24 hours. And our cost for ABPM is actually quite low in terms of dollars, but we do take a refundable deposit from the patient that we return as soon as the machine is returned to us. And with that, we've done several hundred ABPMs and have never lost a machine. So it seems to be working okay. Going now to the interpretation. So what happens once the machine is returned to us? We download the data into the software, and it's important to enter the sleep-wake times that the patient has given to us, because this is what will determine daytime and nighttime blood pressures and help us look at the difference between the two. We also enter the cutoff data, or 95th centile, from the ambulatory BP monitoring normative data, which is different from the auscultatory BP normative data. An ideal study has at least 1 reading per hour for 24 hours. And for research purposes, having an ideal study is very important. However, in the clinical world, even non-ideal studies are still very much interpretable. So if there's an hour missing here and there, we don't worry too much about it. So a word on ABPM normative values. These are not the same as clinic BP resting values. They're actually higher. And if we use clinic values or auscultatory values for ABPM cutoff, that leads to a misclassification. So the only available for now normative data is based on a group of around 1,000 white European healthy children, which gives percentile values based on height and sex. And this has its limitations, understandably, but this is what has been used since these normative data came about. Another weakness of this data is that if we look at an auscultatory normative data chart, a child's diastolic blood pressure normally goes up as the child increases in height. However, the ABPM normative data shows very little diastolic BP variability. And so therefore, making a diagnosis purely on diastolic blood pressure alone sometimes is a little bit less reliable. This is just a sample of the normative blood pressure chart for ABPM. If you note, it looks a little bit different. Then the auscultatory BP charts, it's based on sex, this is for girls, and the height in centimeters. But it has marked the 50th, 75th, 90th, and 95th centile. So let's go into some terminology now before we look at classifying ambulatory BP. So the first thing that we look at is the mean ambulatory blood pressure. And we answer the question, is the mean BP elevated? And we want to know this not just for the 24-hour period, but also separately for daytime and nighttime as well. And the normal value is that the mean ambulatory BP should be less than the 95th centile for the normative data. The second question we ask in pediatrics is, what is the BP load, which answers the question, how often is the BP elevated? And the definition of a BP load is the percentage of readings above the 95th centile, and the normal should be less than 25%. The last important question to ask is there a nocturnal dip? And we want to know, is there a normal circadian fall in the blood pressure at night? This is a formula to calculate it. And essentially, normal nocturnal dip is at least 10%. So when we interpret ABPMs, we basically look at three screens. The first screen on your left basically shows us the number of BP readings that we have and gives us an idea how valid the study is going to be. There's also a place for a patient to enter their blood pressure medications. The middle screen actually provides data on the average 24-hour systolic and diastolic BP, daytime values, nighttime values, and the nocturnal dip. And the last screen on the right gives us a graphical representation of the blood pressure values. If you look at the screen, you'll see these horizontal lines, which are the cutoff or the 95th centile that we have entered in the system. And if you see the lines going above that, you know this patient's blood pressure is going to be well above normal. A little bit extra data we do get from the, at least the Spacelab software, is that you will get every single blood pressure that is measured, that data is available. Also mean arterial pressure, pulse pressure, and heart rate as well. If there are blood pressure readings that are missing in between, if you look on the right, there'll be a column for the event code. And each code, like 90 and 70, stands for a particular issue that has occurred leading to a missed BP value. So I think 90 stands for movement artifact. And so therefore you get an idea, especially if the patient has removed the machine, why there are BP values that are missing. This is an hourly average of blood pressure values. And if you look at the left column, you'll see that per hour, this particular patient had at least 2 to 3 readings per hour. So this is a valid study. So when we look at the staging of ambulatory BP, there are the American Heart Association criteria and the European criteria. And so we look at them both separately. They are similar, but there are a few important differences. I'll not go too much into detail about the values per se, but a normal blood pressure obviously means that both the clinic BP and the ambulatory BP are perfectly normal. White coat hypertension occurs when clinic BPs are high, but that the ambulatory BP is normal. I apologize, the last column on the right for white coat hypertension should show less than 25% for load. There's a pre-hypertension defined when the mean ambulatory BP and the clinic BP are normal, but you have an elevation of BP load. And this is not present in the European criteria. An important category of hypertension is masked hypertension. That's when the patient's clinic BP is normal, but the mean ambulatory BP and the load are elevated. And this obviously points to the fact that the diagnosis of hypertension would be missed if we had just done a clinic BP alone. If both the clinic BP and the mean ambulatory BP are elevated, then the patient has ambulatory or sustained hypertension. And if their loads are above 50%, then they have severe ambulatory hypertension, indicating that they're at risk for target organ damage. The European criteria are similar, but they do not take into account blood pressure load, as do the adult criteria. The adult criteria do not consider BP load to define hypertension. And so therefore the European criteria are very similar, but they have only 4 categories: normal, white coat, masked, and ambulatory hypertension. In a study in KI this year, using the European criteria, actually, because there was the cutoff for the taller children of 130 by 80, it led to more children being treated than the AHA criteria. So this is a more sensitive criteria. A recent study of the C-kid population of 500 children found that ambulatory BP load was not significantly associated with LVH or progression of CKD. This has just been published in April this year, so perhaps we may find the relevance of BP load in pediatric ABPM decreasing over time. So this is a chart which basically explains a practical application of our ABPM classification. In the middle are our ABPM classifications of blood pressure. And if you look at the column on the left, new patients, patients with suspected hypertension, we find that a diagnosis of normal and white coat hypertension avoids unnecessary testing or unnecessary treatment. If there's a diagnosis of masked hypertension, then we have made a new diagnosis of hypertension that would have been missed by clinic BP. And if the patient has ambulatory hypertension, then it confirms that their clinic BP and their ambulatory BP are high, and we can get an idea of their diurnal variation as well. If we look on the right side, we find that in patients who are already on antihypertensive medication, normal or white coat hypertension indicate that the patient's blood pressure is actually well controlled and we don't need to make unnecessary medication changes. In patients who are on medication, masked hypertension means that their blood pressure is uncontrolled, but it is hidden from a clinic BP. And so therefore, this would be a good indication for medication adjustment that would have been missed by a clinic BP alone. A patient whose clinic BP and ambulatory BP monitoring show hypertension confirms that the patient's blood pressure is uncontrolled, and we can also study their diurnal variation and decide how to time blood pressure medications in a better way if possible and increase the dosing. So we move on to the clinical significance of ABPM. This scatter plot basically shows that clinic BP correlates poorly with ambulatory BP findings. This is true in adults as well as in children. Often children with high clinic blood pressures have white coat hypertension, and patients who do have ambulatory hypertension, their clinic BPs will be normal. And so therefore, based on this study of children, they found that ambulatory blood pressure monitoring led to a change in clinic-based treatment in 63% of patients. So this just says that ABPM and clinic blood pressure don't correlate very well. In primary hypertension in children on treatment, clinic BPs were poorly sensitive and poorly specific in deciding whether the patient's treatment was adequate or not. This was a study looking at treated primary hypertension patients, and those who had masked hypertension or had the white coat effect basically were patients who were misdiagnosed by clinic blood pressure. So in the treatment of primary hypertension also, an ABPM is very useful. Obesity is known to affect blood pressure due to the sympathetic overactivity. An important aspect of obesity is the nighttime elevation in blood pressures and non-dipping. And so in this study of obese and lean children with suspected hypertension, 34% of the obese children had a blunted nocturnal dip, and the prevalence ratio of blunted dipping or non-dipping was double that of, in obese children, was double that of lean children. So an ABPM picks up nighttime BP and this important cardiovascular risk marker. We move on now to CKD, a very important indication for ambulatory BP monitoring. This has been well studied in the C-KID study with over 600 patients undergoing ABPM, the youngest of whom was 2 years. Sleep hypertension occurred in 65%, indicating that masked hypertension was common. Not only was it prevalent, but ambulatory hypertension also did a better job of predicting worsening proteinuria compared to clinic blood pressure as well. This is the famous ESCAPE trial. The question is really, can ambulatory blood pressure monitoring be used to strictly control the blood pressure, and does it slow the progression of CKD? And in this graph, we find that patients who were randomized to the intensified group, that is the patients who had less than the 50th centile of ambulatory blood pressure, fewer of them reached their primary endpoint compared to those whose blood pressure was controlled but not so tightly. And the primary endpoint for this study was a 50% decline in GFR. And so therefore, this study gave us data that not just BP control, but intensified BP control would be necessary to delay the progression of CKD. As we know, pediatric CKD involves both glomerular disease as well as non-glomerular disease, and intensifying the blood pressure control in both the children with glomerular CKD as well as those with non-glomerular CKD led to the reduction in decline of GFR. So it works for CKD of all kinds. ABPM is a strong predictor of left ventricular hypertrophy in children. This is a study that looked at left ventricular mass index and LVH in children with normal blood pressure, in those with clinic-based stage 1 hypertension, that's the gang on the right, and in patients who had white coat hypertension and masked hypertension in the middle on ABPM. And what the study showed was that although patients with white coat hypertension had prevalence of left ventricular hypertrophy similar to those with normal BP, patients with masked hypertension had a prevalence of LVH similar to those with stage 1 hypertension. So this was the group that would have been missed by clinic blood pressure. And if we look at the adjusted odds ratio at the last line, the odds ratio for ABPM predicting LVH is strongest in the group with masked hypertension. So therefore, ABPM is a better predictor than clinic BP for LVH. We know that children on dialysis have a very high prevalence of hypertension. Only 13% of patients studied actually had controlled blood pressures. This is a tracing, the diagram, the picture on the right is a tracing of one of our patients with FSGS who went into ESRD. And this shows how poorly controlled his blood pressure is despite being on regular dialysis and being compliant with antihypertensive medications. So this gives us a clue that we need to intensify fluid removal probably and adjust our antihypertensive medication, advise on salt intake, etc. Moving on to children with a kidney transplant, multiple studies have shown that the prevalence of hypertension is very high in children post-transplant, and it is predominantly nocturnal and therefore would be missed by a clinic blood pressure. In addition, if we use ABPM to control blood pressures, it has been found to have better graft function and a reduction in proteinuria as well. A word about a non-renal indication, coarctation of aorta. This is in children after repair. And if we look at the diagram or the picture on the left side, we find that post-repair, their arch doesn't, to my very untrained eye, look particularly normal. And so therefore, we know that 30% of these patients have sustained hypertension and go on to early cardiovascular disease. And so therefore, the AHA recommends that the ambulatory BP monitoring is the gold standard for hypertension diagnosis in surveillance post-coarctation repair. I'll mention some other causes for, ABPM as well. Among the renal diseases are those with renovascular hypertension, renal artery stenosis, syndromes associated such as neurofibromatosis and Williams syndrome, and patients with Charcot and renal scarring. The non-renal indications are also very important. They include obstructive sleep apnea due to the risk of masked hypertension, type 1 and type 2 diabetes because elevated blood pressures or lead to microalbuminuria, other solid organ transplants, and patients with a history of prematurity and small for gestational age because of their risk for future hypertension. And so to summarize the utility of ABPM, I'll give you a summary of what the guidelines say for using ABPM in children. If we look at the category for diagnosis of hypertension, it is recommended by both guidelines to confirm hypertension in those with elevated BP and stage 1 hypertension, as well as to confirm hypertension before starting treatment. The American Heart Association guidelines recommend performing an ABPM prior to evaluation of stage 1 hypertension to save on cost, unnecessary cost of treatment. It is also recommended to detect hypertension in high-risk patients, that is with CKD, transplant, diabetes, coarctation of aorta, obesity, and obstructive sleep apnea. During the treatment of hypertension, ABPM is recommended by both guidelines to assess the effectiveness of BP control. It is recommended in CKD to be performed at regular intervals as well to ensure that blood pressure control is strict. And the European guidelines recommend ABPM in clinical trials of hypertension. So what are the recommended ambulatory BP goals? A general blood pressure goal for any hypertensive patient would be to lower their blood pressure, ideally less than the 90th centile. In diabetes, there should be strict blood pressure control, and it is recommended to lower it at least to the 75th centile and to less than the 50th if they are proteinuric. Similar guidelines exist for children with CKD as well. Should we repeat ambulatory blood pressure monitoring? We know it's a little bit cumbersome and expensive for patients. So it is recommended to repeat it if the patient has severe hypertension to assess if their BP control has improved. If they have target organ damage like LVH, to ensure that their blood pressure control is adequate. It is also recommended in CKD and transplant at regular intervals for medication adjustment. White coat hypertension in adults has been shown to be associated with cardiovascular morbidity, and in adolescents, white coat hypertension has been shown to be associated with sustained hypertension in at least a quarter of the patients. So patients with white coat hypertension do require follow-up ABPMs to ensure that their blood pressure is not becoming sustained as well. When we look at cost effectiveness, this was an American study that was performed in children who were suspected to have white coat hypertension. And this was looking at the saving of costs related with extensive investigations that would have occurred if the child's clinic BP was used to decide on management. And this study basically showed that if ABPM showed white coat hypertension, there would be a significant saving in costs. Now, I'm not sure if this particular study on cost effectiveness would be applicable to other regions around the world, and it may not be applicable to such an extent in our setting in India. But we also have to consider the long-term cost effectiveness, which nobody has studied, of missing blood pressures, uncontrolled hypertension, and long-term costs, direct and indirect, associated with cardiovascular morbidity. So in summary, I think ABPM is probably cost-effective in the short term as well as in the long run. A few words on doing ABPM in India, which mostly has poor patients and in low resource settings. So I'll go through these slides briefly. This essentially was an early feasibility study which showed that the management of patients changed significantly in patients with ABPM. And this particular study, a lot of the patients had normal blood pressures and also had white coat hypertension. This is looking at our center's indication for performing ABPM. Our patients, all the ABPMs that we have performed, the majority have been for CKD and transplant, but also for other glomerular diseases like nephrotic syndrome, and a much smaller number for suspected white coat hypertension. This is a study from AIMS looking at the prevalence of ambulatory hypertension and nephrotic syndrome. And it was basically found that almost 50% of children had either masked or ambulatory hypertension. And this correlated with an early onset of disease, as well as the duration of frequent relapses, probably indicating exposure to steroids. CKD has been studied for ABPM in Indian children. And in this study too, prevalence of ambulatory hypertension was high, and the LVH correlated with ambulatory BP indices. And lastly, in transplant, this is a study performed at our center. We found that post-transplant nocturnal hypertension, the purple bars are the nighttime values for blood pressure, mean blood pressure, as well as blood pressure loads. Well, the nighttime values were much higher than the daytime values in green. We actually did repeated measures and found that even though blood pressure values improved over time on repeated ABPM, this nocturnal elevation pattern persisted. So let's discuss some limitations of performing ABPM. Of course, the monitor is expensive and it is not available in all parts of the world. It does have age limitations. It's really difficult to perform in children who don't allow the monitor to be placed and to keep it on. The normative data has its weaknesses, as we've discussed before. It has no normative data for short children, less than 120 centimeters. So that's a challenge in our setting, especially when patients have quite a bit of short stature, especially in CKD. The normative data generalizability, do the normative data of European healthy children, is that applicable to children in different parts of the world? That's not known. And most importantly, ABPM data, though it does predict surrogate cardiovascular markers, there are no hard outcome data yet in children. The chart on the right shows that some monitors do have quite a bit of variability in measuring the diastolic blood pressure. So again, diastolic BP is not as reliable as systolic blood pressure values on ABPM. So in conclusion, ABPM is considered now standard of care for management of pediatric hypertension. It is important to use validated equipment for children and to have trained staff. We recommend following the AHA or European Society's classification for staging of blood pressure. ABPM is useful both for the diagnosis and treatment of hypertension. It's essential, however, for high-risk groups. And ABPM in low-resource settings is both feasible and affordable and recommended. And we need more studies published from our settings. Our goal is therefore ultimately to reduce current and future cardiovascular risk that is really among the highest in South Asia and Southeast Asian countries. And so with that, I'll include. Thank you very much. And I think Dr. Kalaivani, are we good?
Yeah,
want to take questions now?
Yeah. Dr. Manoj, are you there?
Yeah, I am very much there. Can you see me?
Yeah. Yes.
Yeah. Okay. Thank you so much, Dr. Pais, for this elusive outlook of ambulatory blood pressure monitoring. Let's move on to the questions. Kalaivani, you want me to moderate the questions, right?
Yes.
Correct? Okay. Fine. Thanks. So
if I may
I'm just going to...
I'm sorry.
Sorry?
Sorry, can you hear me? I'm sorry.
Yeah, we can hear you.
Yes, but I have some patients waiting. So if it's not too much to ask, if you can go over my questions first, I apologize for jumping in.
No. Actually, I was just going to do that itself because I'll be asking you your first questions and I'll take the other ones later. No problem. That's fine.
Thank you. I really appreciate it.
No worries. That's all right. So the first question for you, Roshan, is a nephrotic syndrome patient, steroid-resistant nephrotic syndrome, that's what they're asking, should be administered statins. So if so, how long, especially when the patient has not developed CKD? So statins for CKD.
Yes, that's a great question. And I know that with statins, there's always a lot of controversy, whether it's CKD or with nephrotic syndrome. There are not a lot of studies that show benefits. There are cardiovascular benefits that are there that are shown, but not benefits in nephrotic syndrome or benefits in reducing progression of CKD. So at this time, also the risk is not very clear in pediatric patients. So anecdotally, there are lots of areas that show that these patients, especially with nephrotic syndrome, have higher myopathy and muscle-related side effects, especially because of intravascular volume depletion with hypoalbuminemia and other risks with edema. So at this point, there is not a lot of data suggesting that automatically these patients should be started on statins. It is a little bit more, I think, a weighing of a nuanced approach to say that if they have very high levels of LDL, normal like family history of hypercholesterolemia, then this could be done with checking of CPK levels and making sure that risk factors are mitigated. But there's not guidelines saying that as a blanket these patients should be started on statins. Treating the nephrotic syndrome, as we all know, which is difficult in these patients, is the treatment for their abnormal levels. But I know it's challenging.
Right. A similar question I think you've already answered, that what is the role of treatment of dyslipidemia by statins? So as you already mentioned, that dyslipidemia you can use, but not for decreasing the progression to CKD. So I think that it answers that same.
Yes.
Now we have another question.
I will just jump in and just say also that, KDIGO guidelines do not actually have statin as treatment for in CKD with LDL, like using LDL levels to adjust statins and treat. However, lifestyle changes is what is proposed for at least 6 months. So if there is dyslipidemia, using lifestyle changes, and if in spite of lifestyle changes, if LDL levels are really high, over 160 or over 190, those are kind of the two levels that are kind of mentioned that you could consider. But again, it's not a very strong evidence or strong push to use it.
Right, thank you. We just have another question for you, and that will be the last for you, but it's a big question, so bear with me for that, sorry. We have a child on HD for last 3 years. He came to us last year with severe hypertension, CCF, and ejection fraction of 18%, very low. Thereafter, on almost daily slow dialysis, we have managed to control the blood pressure, and the current ABPMs are normal. And echo and USG do not show any evidence of fluid overload. She is on cardio-waste, but despite all of this, the ejection fraction is still low, which is 18 before and now 22% after 1 year. So the question is, the cardiologists feel that the chronic cardiac failure is irreversible, and anesthetists have refused the clearance for kidney transplant. So what would be your suggested plan of action? The question basically burns down to fitness for transplant, because the cardiologist is not giving, because it's chronic cardiac failure, according to him, which is irreversible.
So this is a very difficult situation, and I am sorry to hear this. I see this as almost an irresolvable problem, especially if this cardiologists and anesthesiologists are kind of firm on that, because we also encountered this not very frequently, but a few years ago, where we had a similar presentation, and to be honest, we also didn't have a solution. We ended up with that child finally going to palliative care, which was really heartbreaking. But, if there is no improvement, because like I was saying during my talk, that after certain points, some of these conditions are truly irreversible. However, you are on the right track with controlling the blood pressure. The patient is on cardiovascular. You have more time to give the patient, because you've already seen some improvement. And I'm not sure if the patient is on daily dialysis as PD now, but if that is a possibility of continuing for some more time. It is difficult because the families also lose motivation when there is no light at the end of the tunnel of having done so well and no transplant dates coming up. But I would recommend just pushing on. You're on the right track. So that I don't have anything else, unfortunately, specific to recommend, because we had been in the same situation and ended up not having a transplant for that unfortunate child.
No worries. Thank you so much, Roshan, for your answer. And I think your questions are all over. So I think you can leave if it's fine. Or if you want to hang around, no worries. Thank you.
No, thank you so much. I appreciate the opportunity. And thank you so much for listening in, everybody.
Okay. Thank you. Thanks. It was a pleasure to have you. Okay, so now I move on to, I'll take my questions, immunization later, that seem to be more than others. But let me go to Priya's questions. The first one is they're saying, thanks, it was a good talk. ABPM, the question is, ABPM to be done in 5 years or more, and in one research, it was done in 2 years. So is there a normal percentile chart for 2 years?
The normative data charts actually are based on height. And so they start only at 120 centimeters. And I'm not really sure how a 2-year-old underwent ABPM, maybe a very tall Caucasian child. But the reason we don't do it under 5 years is not really an age issue, but whether they will tolerate keeping the machine on for 24 hours. So I have done it for a 5-year-old who was 120 centimeters tall. But if there is no normative data for less than 120 centimeters, and then it's a bit of a struggle deciding how to interpret that. So in general, I would stick with 5 years and above, and it's easy to interpret if your child is at least 120 centimeters.
All right. The next question for you is, what will be your best advice for blood pressure monitoring in younger children?
In younger than 5 years?
I mean, there's no mention of the younger age, yeah. But
I'm assuming that's what it is. So in our younger patients, I think pediatric guidelines do not, especially the AAP guidelines, do not recommend home BP monitoring. So I would not advise patients to invest in an oscillatory home BP monitor, because most often they are poorly validated and incorrect. So practical suggestion would be that we see these patients a little more often, or we often ask the local physician, primary care physician, to measure a blood pressure, and then they write it in a diary and bring it in. And we have trained few parents to do a palpatory systolic BP, the ones who are willing to learn. And that is also quite a simple way to measure a blood pressure with an apparatus that is quite inexpensive. So frequently we see them back if they can't get blood pressure measurements outside.
Okay, fine. Thank you. As I said, no questions on immunization. So Kalaivani, I'll just go ahead with my questions. Is that okay now? Yeah. So, I mean, please feel free to add on to anything if you feel like. Priya, no, please. The first question is, can live vaccines trigger renal allograft rejection? Okay, good question. As I showed you, those two studies, those people who were very bold, and one was a liver transplant and the other was the kidney transplant. They had given those two live vaccines. I think one was MMR and the other was varicella. And they didn't really have any rejection, but I think we should not be so bold enough, because transplants for us in India are like a very important ball game, and we really spend a lot in that. Any vaccine, whether it's live or killed, can be an immune trigger for the suppressed immune system. So I think we should not unnecessarily venture into that. But your answer would be those two studies at least didn't show any rejection. They were bold enough to do. The next question is, earliest, when can we vaccinate after giving blood products? So I think I mentioned in one of the slides, 6 months. 6 months is usually the cutoff whereby all the those inhibiting factors which are there, which if you vaccinate and those inhibiting factors from the plasma or from the blood are there, they will be wiped off. The bone marrow usually gets stimulated after 3 or 4 weeks, and by 4 weeks, usually it is said that you produce your own blood and your own plasma, but studies say 6 months. So I would really wait for 3 to 6 months, if not 6, at least 3 months. Another question is, if close contact of varicella is asymptomatic, still we have to administer immunoglobulin even if the patient is off steroids for a month. Yeah, another good question. So if you feel that the close contact is asymptomatic, but you never know if the child has no rash, the child may be incubating as well, we never know. So we can obviously just wait for the progression. And the child, I think it's a nephrotic child you're speaking, the child is off steroids for 1 month. So the child is quite safe. So we can just wait and see the evolution of the disease, what is happening. So we don't need to rush and give varicella zoster immunoglobulin that time. Another question is, dose of influenza vaccine is same for nephrotic patient and general patient? I mean, so far, I have not found a difference in the dose mentioned anyway, so I presume it's the same, unless someone has another answer for that. Next question is, how to vaccinate a steroid-dependent and frequent relapsing? He's mentioned the further details. If a patient is diagnosed as new-onset nephrotic syndrome with proteinuria, should we vaccinate before starting full dose of steroids? Okay, this question, I mean, you have to look at the child. If the child is having severe proteinuria and edema, I think the treatment of nephrotic syndrome takes precedence over your immunization. So once you finish the 6 weeks daily followed by 6 weeks alternate day, I think your vaccination can resume after that. And they are saying that if we start the vaccination before treating the first episode, should we start steroids after vaccination? Yeah, so that's what. So if you give vaccine, there'll be poor seroconversion if you immediately give steroids. So the best thing would be to hold on for the vaccines for a while, treat the nephrotic because that takes precedence and vaccination can always be done later. That question also had, as I said, how to vaccinate a steroid-dependent frequent relapser. So frequent relapsers are easy to vaccinate because at least they are off steroids for some time, so you can take the advantage of doing that. Whereas in a steroid dependent, usually we look at the dependence threshold dose of that. Anything below 0.5 mg per kg per day, alternate day, if the child is on steroids, we usually find that quite safe. So though they are on that, we don't categorize them in the immunosuppressed, so we can give the vaccine safely. And I think, yeah, there were 2 other questions as well in the end. There's one more for vaccination. After what interval one can vaccinate the child with nephrotic syndrome with blood culture positive streptococci pneumoniae infection after completing treatment? So I presume the question is a nephrotic child who's got spontaneous bacterial peritonitis and the blood culture has grown pneumococci. So obviously you have to treat it properly. I would say at least if your blood is positive, at least properly 7 to 14 days. And if the child is stable, 7 days IV followed by then next 7 days oral, but complete 2 weeks proper. And the question is how much can you wait? I think if you have such a child with peritonitis, you have treated, obviously your child will become stable once the infection settles, and then the child will be on, depends whether it's a relapse or it's a first episode. So you all know that in the relapse we give, after the child is in remission, then we go on to 1.5 mg per kg single dose alternate day for 4 weeks. So that's 1 month. Whereas if it's a first episode of nephrotic presenting as bacterial peritonitis, then 6 weeks daily, steroids will go on, and then after that 6 weeks alternate day. So in the first episode, your vaccination will be prolonged later compared to a relapse. But once the child is off steroids, we say at least for around 2 to 3 weeks, you can safely give the vaccines. So, okay, one more question for Priya has just come now. I'll just take it. Which BP instrument we can recommend for monitoring BP at home, age-wise?
That would not be an ambulatory BP monitoring, I assume. That would just be an oscillometric device. There is really so many of them out there. I think the website that I had shown earlier does say whether some oscillometric machines are validated in pediatrics. Regardless of that, a practical suggestion, if you are going to do home monitoring with an oscillometric machine, is to actually bring it to clinic And it can be compared with an auscultatory BP to see how much, if there is a margin of error and how much there is. But my general advice to parents who want to monitor blood pressures at home is to not do it too frequently. I give them cutoff values. If it's twice above this value, then they have to come into clinic and confirm it, because oftentimes a oscillometric devices give very variable readings. Sometimes they're really high, sometimes they're really low, and it's important to advise parents not to adjust blood pressure medications on their own based on these home BP machines. So again, to reiterate, home blood pressure monitoring with oscillometric devices or electronic devices is not recommended actually for children, which is different from adults, where it is accepted that home BP monitoring is an important part of BP management.
Okay, thank you. And I would just take a last question, which is there, again on vaccination. That's the last for the day. Can we vaccinate children steroid dependent on tacrolimus? Yeah, so tacrolimus is a very strong immunosuppressant. As you know, it's a calcium inhibitor. So when the child usually is on tacrolimus dependent, usually we give it for around 1.5 to 2 years, and then the child will be off for some time. So that some time can be utilized to vaccinate for the live ones, but you can give away safely the killed ones. But as I said, even if you give killed vaccines, the child is immunosuppressed, your seroconversion may be poor. So I think if the child is in the age group beyond 5 to 10 years, so the child has usually finished his primary vaccination till 5 years. So we can wait, let the tacrolimus be off. Usually after 1.5 2 years, the child will be off tacrolimus and maybe on a little bit of alternate day steroids. That is the best time to vaccinate live and killed as well. But otherwise, if you're in a dire emergency, killed vaccines can be given on tacrolimus. So I think that's it. Questions for the day. I don't know, there's just one more popping up. Should I take it, Priya? And how can one do 4-limb BPs using ABPM, 4-limb blood pressure?
4-limb blood pressure would be a one-time measurement, and so therefore you don't need an ambulatory 24-hour blood pressure monitoring for to do 4-limb BPs. If you really would like to do a 4-limb blood pressure to, for example, rule out the coarctation, if you're doing it, sometimes an oscillometric device is simple for this. You will need to use a larger sized cup on the legs. You could put it over the thigh or the popliteal area and compare your upper limb and lower limb blood pressures. The exact values may not be so important as to whether the lower limb blood pressures are above the upper limb blood pressures, which is important. You can also do 4-limb blood pressures by auscultation, especially in the popliteal fossa, but this is more difficult to do. So the role of an ABPM would not be for 4-limb BPs, but a simple oscillometric NIBP machine will do the job for you using 2 different sized cups, one for the arm and a larger one for the legs.
Fine. Thank you so much. Over to Kalaivani for your last concluding remarks. I hope there are no more questions.
Like there are no more questions, we extended time as well. I think it was a wonderful session. Thank you so very much, Dr. Manoj and Dr. Priya. Thank you for the excellent session. Thank you.
Thank you.
Bye-bye.
Thank you very much. Bye.
Thanks. Bye.
Bye-bye.
So we can just log off, right?